Good morning, everyone. Welcome to our summer webinar, Communicable Disease Forum. Today is August 13. We have the next 2 hours. We hope to enjoy the topics for today's webinar. So today's webinar, as always, will be recorded and archived and will be posted also on our website. There is 2 public health and nursing credit for today for attending today's webinar. Credit will be provided only to those who attend the webinar live, and you also must be registered on GoToWebinar and NJLMN. Please, if those viewing the webinar in the archived status, means after the live today, after the live webinar, you will not get credit. Your lines are muted. Please use question box to ask questions. Questions will be answered at the end of the webinar. There is 2 ways to see the handouts. Now, while we are doing the live webinar, you can see the handout, and also you can retrieve the handout from NJLMN in Practice Exchange, and an email was sent yesterday for this. After today's webinar, you will receive a link for the evaluation. The evaluation link will be sent in your NJLMN email address. If you are seeking continuous education credit, you must complete the evaluation within 5 days after receiving the link. The evaluation link will be, or the survey will be closed on August 19th. After the evaluation closes, certificates will be emailed to the address we have in NJLMN, and attendance will be verified for public health credit. Those who do not complete the evaluation will not receive the credits. You always know that. Just a reminder that our next webinar will be August 29. It's a Tuesday, and it's also in the same time, 9:30 to 11:30 in the morning. Today we have several topics on hepatitis A and hepatitis A outbreak that's going on in the state right now. Hopefully you will get some information and some update. Our first speaker is Pinar Ordodo, and the topic is identifying resources relative to drug-related overdose deaths and blood-borne pathogen.
Good morning, everyone. I'm Pinar Ordodo. I work for New Jersey Department of Health as Health Data Specialist. I currently work on surveillance data to understand disease trends in New Jersey for diseases like hepatitis and foodborne illnesses. Today, I will be talking about our analysis results from opioids and bloodborne pathogens vulnerability mapping project. This project is funded by CDC. New Jersey Department of Health partnered with New Jersey Association of City and County Health Officials to complete the project. And CHACHO collected some of the data sets, and also New Jersey Department of Health collected some of the data sets, and then New Jersey Department of Health created maps to display the trends. So first, I will start with introduction and project objectives, and then I will go over methods, and then I will talk about results, and at the end, I will talk about the summary and our next steps. So why do we care about opioid overdose epidemic? CDC estimates that there are 130 Americans die every day from opioid overdose, and there are 46,000 people died overdosing opioids in 2017. With increased injection drug usage, it also increased the risk of bloodborne pathogens transmission, and that resulted in higher number of hepatitis B, hepatitis C, and HIV cases. In 2017, Health and Human Services declared a public health emergency, and they announced 5 priorities to fight opioid epidemic. One of them was improving access to treatment and recovery services. In the next slides, we will start exploring some of the treatment and harm reduction services in New Jersey. So our objective in this project was to examine the services available in New Jersey for areas at high risk of opioid overdoses and bloodborne pathogens associated with drug injection. This information only represents what resources look like in 2017, and we are currently trying to determine if this information is useful and if needs to be updated annually. So this project consists of 2 parts. The first part is the GIS mapping, which we will talk about in this presentation. And the second part is the vulnerability assessment. It's still in process. Here you are looking at the data sets we used to create maps. There are 16 different data types here. The only thing missing here is the hepatitis B. Well, we didn't have sufficient number of cases at municipality level, so we excluded the hepatitis B data. Most of the data sets here are publicly available and provided by NJDOH. Some of them were extracted from databases. Again, please keep in your mind this data is from 2017, which was the most current information when we started the project in 2018. We use geographic information system to create maps. For those who are not familiar with GIS, it's a tool that allows you to visualize disease trends, drug usage trends, or other related issues as a map. As shown in the image below, the software brings together the data and geography and creates the output on the right. Another feature we used in GIS is geocoding. Geocoding helps us to transform a physical address into a location in the map. And these 2 examples you'll see in the coming slides. Okay, those are the first maps. The map on the left is showing the number of overdose deaths in 2017 by municipalities. As red color gets darker, number of overdose deaths increase. As you see, there are pockets of high overdose deaths at different locations. The areas with white colored represent less than 5 cases. And the map on the right is showing naloxone administration by emergency medical services by zip code. As green color gets darker, the number of naloxone administration gets higher. We are seeing same pockets of high number of overdose deaths and naloxone administration in similar locations. For example, I want to show you an example here. If you look at, for example, the Essex County area, you are seeing Newark City or Irvington is orange area with higher number of overdose deaths. And similarly, if you look at here in the naloxone administration map, you are seeing, again, higher number of naloxone administrations in the Newark City, Irvington is orange area. Sorry, I'm trying to change the slide. Okay. Next, we look at the poverty level data on the left side. As blue color gets darker, percent of individuals living below poverty level increases. The map on the right is showing percent of individuals unemployed by municipality. As red color gets darker, unemployment rate gets higher. Again, in both maps, we are seeing similar trends. There are pockets of high rates in different municipalities. And as an example here, I would like to show you here in the Camden County near Philly area, poverty level is higher here, and similarly we see Camden areas, similar location, we see higher unemployment rate. This map is showing number of drug arrests for possession or sale by municipality. As blue color gets darker, number of drug arrests get higher. One thing took my attention in this map, the northeast of New Jersey, we see higher drug arrests. In addition to that, like if you go south, for example, counties like Camden, Gloucester, and Atlantic experiencing higher number of drug arrests. I just want to mention here, this information is also available at New Jersey Department of Health's opioid dashboard, if you would like to have more information. Next, we look at the infections that are linked to the opioid crisis because they are transmitted through shared syringes and other injection equipment. The map on the right, the map on the left is showing 2017 hepatitis C rates by municipality. As blue color gets darker, the hepatitis C rates increase. The map on the right is showing HIV rates by county. In both maps, again, we are seeing similar trends. There are pockets of high rates at different locations, but just want to give you an example. If we look at the Camden area near Philly here, we see higher number of hepatitis C rates, and Camden also has higher HIV rate. Another example, Cumberland County with higher HIV rate. And on the left, if you look at the HCV map, we see municipalities with higher HCV rate. So this slide and the next slide, they are new. We recently added the hepatitis A data to this presentation because usage of contaminated needles or other injection drug preparation equipment increase risk of hepatitis A infection. So New Jersey is experiencing higher hepatitis A cases this year. Since December 1st, 2018, which is the outbreak start date, New Jersey had 316 confirmed cases. In 2017, we had 71, and in 2018, we had 70 confirmed Hep A cases. In this maps, you are looking at the rates by county. The first map on the left is showing 2017 rates. And if you look at the legend, the rates are ranging from 0.1 to 7.2. And you see some of the counties with no cases. And if you look at the map in the middle, which is showing the 2018 hepatitis A rates, again, you see some counties without any case, and the rates, if you look at the legend, it's lower, ranging from 0.1 to 4.0. When we look at the map on the right, it's showing only outbreak cases since December 1st until August 3rd. You see the rates increased. It's ranging from 0.1 to 22.3. And there are counties with higher hepatitis A rate. They are in the southern region of New Jersey, such as Gloucester, Camden, and Salem. Next, we wanted to see the risk factors associated with hepatitis A cases in this outbreak. Here we are seeing about 60% of confirmed cases in the outbreak indicate using injection and non-injection drugs. And the next bar is showing 23% of cases experience homelessness, and 10% were incarcerated within 2 to 6 weeks of symptom onset. I will start showing maps for locational services. Before that, I would like to provide description for 2 terms. The first one is harm reduction and prevention services. In this project, It refers to a range of services help reduce the adverse consequences of drug use. And we covered services like syringe access, blood-borne pathogen testing sites, municipal alliances, and RX drop boxes. And next, we look at the treatment services. In this project, it refers to services provided to relieve withdrawal symptoms and psychological cravings due to the opioids. In this project, we covered sober living houses, opioid treatment programs, medication-assisted treatment locations, drug detox locations, and drug rehabilitation locations. Both of these services are very important because they prevent overdose deaths and reduce transmission of blood-borne pathogens. So we created maps for each county. Because of the limited time, I selected only 3 examples. Here you are looking at the harm reduction and prevention services in Atlantic County. I selected Atlantic County because it has both urban and rural sections, and we wanted to see how data looks in a county with both rural and urban. So you are looking at the services like syringe access locations, blood-borne pathogen testing sites, municipal alliances, and RX drop box locations. The location of harm reduction and prevention services are mostly located in the east section of the county. When you look at the west, there are services, but it's not as much as the east section. Next, we look at the treatment services in Atlantic County, and specifically, we look at the services sober living houses, opioid treatment programs, medication-assisted treatment locations, drug detox locations, and drug rehabilitation locations. Similarly to the harm reduction and prevention services map in the previous slide, we see most of the treatment services located in the east section of the county as well. Yeah, when we look at the west area, there are services, but it's not as much as this area here. Next example is from Cumberland County. The reason I selected Cumberland County because it's a rural county, and CDC found that the opioid overdose epidemic affected mostly the rural areas. So here again we are seeing similar trends. Most of the services are located in the 2 areas here. One here and the second one here. We see services down here, but it's not as much as the north section of the Cumberland County. Okay, and this map is showing the treatment services in Cumberland County. Again, I think it's more obvious in this map. Treatment services are located in the northern area of Cumberland County. Same areas. And this time when we go to south, there are no services for treatment. Final example is from Essex County. The reason I selected Essex County because it's highly populated and it's near New York City. Compared to the previous examples, Essex County definitely have more services available. But again, similar trends. We are seeing most of the services are located in this area. Compared to this area, there are services here too, but we see a lot of blood-borne pathogen testing sites in this Newark, Irvington, and East Orange area. And the final map from Essex County is showing the treatment services. Again, the difference is more obvious in the treatment services map. Most of the services are located in the east section of the county compared to the west section of the county. So this is an introductory analysis to understand the trends and understand where the services are located in New Jersey. These results are subject to change because if we receive more data, there will be more services. And our next step is we're going to focus on vulnerability assessment, and we're going to look at various indicators to determine if these make municipalities more vulnerable for blood-borne pathogen transmission and opioid overdose. And finally, this information can be used by stakeholders to educate on policies and procedures for distribution of services. I would like to thank Laura Taylor, Hepatitis Coordinator, and Stella Tesai, Surveillance Data Coordinator, and Teresa Hamby, Data Analyst, for their mentorship during this project. And one more thing I would like to mention, these maps are available at NJDOH's website. If you go to their website, it's under resources. If you can't find it, feel free to email me. Thank you.
Thanks, Pinar. Lots of information to digest. We are still on the hepatitis A mood, and our next speaker is our own program from Regional AP program, Brett Nance, and she will give us update on the hepatitis A outbreak.
Thanks, Sharif. Good morning, everyone. As Sharif said, my name is Brett Nance. I am a regional epidemiologist at the Communicable Disease Service covering Southern New Jersey. Today, I'll be providing a brief update about the ongoing hepatitis A outbreak that's occurring in New Jersey. The topics that will be covered in this webinar section include reviewing the updated hepatitis A case definition, providing an overview of the hepatitis A outbreaks occurring nationally, sharing information on the current status of the outbreak in New Jersey, and discussing outbreak response efforts from both the local health department and Communicable Disease Service perspective. The last slide in this section also provides you with a few links to resources that you can access. To begin, the hepatitis A case definition was updated in late June. This new case definition provides more specific parameters in classifying confirmed cases of acute hepatitis A, mainly with regard to clinical signs and symptoms and liver function test values. The clinical criteria for our new case definition includes an acute illness with a discrete onset of any sign or symptom that's consistent with acute viral hepatitis, including fever, headache, malaise, anorexia, nausea, vomiting, diarrhea, abdominal pain, or dark urine. The case must have jaundice or a bilirubin of 3 or higher, or an ALT greater than 200, along with an absence of a more likely diagnosis for the signs or symptoms and elevated liver function values. Laboratory criteria for our new case definition includes either a positive Hep A IgM or a Hep A virus RNA detection via a NAT test such as a PCR or genotype. So in terms of the case definition, a confirmed case of acute hepatitis A will meet both the clinical and laboratory criteria that was discussed. Additionally, a case can be a confirmed hepatitis A case if it meets the clinical criteria and is epidemiologically linked via household or sexual contact with a laboratory confirmed case of hepatitis A in the 2 to 6 weeks before symptom onset. As a reminder, we are still seeing a significant increase in the number of confirmed hepatitis A cases in the state. However, false positive Hep A IgM results do still occur on a regular basis. All reports of hepatitis A virus IgM positives should be investigated in full to determine signs or symptoms and liver function test results. If a case does not meet the clinical criteria for a confirmed case definition, it should be LHD closed as not a case. Additionally, with the adoption of this new case definition, we are no longer using the probable case definition for hepatitis A. So on to hepatitis A outbreak overviews at the national and state perspective. The initial increase in hepatitis A cases was first observed by CDC in 2016. Upon investigating these increases, the following groups were identified as those at highest risk for acquiring the disease. People who use drugs, both injection and non-injection, people experiencing unstable housing or homelessness, men who have sex with men, and people who are or were recently incarcerated. Since the outbreaks were first identified in 2016, there have been 29 states that have publicly reported over 23,000 cases of confirmed hepatitis A, over 14,000 or 60% hospitalizations, and over 200 deaths as of August 2nd, 2019. Additionally, since these outbreaks were first identified, many states have had large outbreaks, some with even thousands of cases that have been reported. Per CDC, states that have been able to quickly implement prevention measures such as vaccination, community outreach, and education have been able to keep their case counts low. As you can see, this map illustrates all 29 states who have publicly reported hepatitis A outbreak cases across the United States. Higher case counts are being seen in the Central East, Southeast, and Mid-Atlantic regions. Just for some background information, in 2016, Michigan and California were the first two states to declare their outbreaks. In 2017, Utah, Indiana, Kentucky, Missouri, and Tennessee all declared their outbreaks, and all other states that are displayed on this map have either declared outbreaks in 2018 or 19. Since that time, California and Utah have been the only states that have declared their outbreaks over. And as previously stated, the states that are seeing these outbreaks are also among the high-risk populations of those using illicit drugs, experiencing homelessness or unstable housing, men who have sex with men, and those who are or were recently incarcerated. So given the knowledge of other outbreaks occurring across the country and other states, New Jersey Department of Health has been closely monitoring cases of hepatitis A. At the beginning of 2019, in early February, the Communicable Disease Service identified an increase among a few of our southern counties in New Jersey, including Burlington County, Camden County, and Gloucester County. We retrospectively reviewed cases back to December 1st of 2018 to assess if smaller increases had gone unidentified in the months before February. As you can see from this epi curve, sporadic cases of confirmed hepatitis A were reported through December 2018 into mid-January. A small increase in the last week of January was followed by a slightly larger increase in the beginning of February, which is displayed in the red box on your screen. This is when CDS identified that there was an issue occurring, and a further look at these cases revealed that most shared similar risk factors of drug use and homelessness. Around this time is when the affected local health jurisdictions and the Communicable Disease Service began discussing the increase in cases and brainstorming ideas for outreach efforts into the high-risk populations within the local health jurisdiction communities. To provide you with some comparison data and context on the number of confirmed hepatitis A cases that are being reported, during the current outbreak period of December 1st, 2018 through August 3rd of 2019, 342 total cases of confirmed hepatitis A have been reported to the New Jersey Department of Health. 316 of these cases meet our outbreak case definition, which will be reviewed momentarily. In comparison, during the same time period last year in which there was not an ongoing outbreak of Hep A occurring, only 49 cases of confirmed hepatitis A were reported to the New Jersey Department of Health. Since the initial increase in cases was identified, we have been working closely with you all as local health partners to investigate and describe cases associated with this outbreak, as well as work on outreach efforts and outbreak response strategies. As of August 3rd, 2019, New Jersey is reporting 316 outbreak-associated cases of hepatitis A among all 21 counties. As you can see from the county level breakdown of cases, the southern counties are still largely affected by this outbreak, including our initially affected counties of Camden, Gloucester, and Burlington. Additionally, increases in cases are now being identified in other counties such as Mercer and Passaic as well. Of the 258 cases in which hospitalization data is available, 219 or 85% of the cases have been hospitalized. We are a little bit above the curve in terms of hospitalization rates for this outbreak. Overall, hospitalization rates are higher for the outbreaks that are being seen across the country. New Jersey is also reporting 3 deaths associated with this outbreak, and a question may come up about what a death is considered for this outbreak. So a death is considered to be associated with this Hep A outbreak if the death certificate of the case patient lists the ICD-10 code for hepatitis A as either an underlying cause of death or one of the multiple causes of death. The Communicable Disease Service uses 3 different case classifications in order to come to the total number of outbreak-related cases that are reported out each week on our website. A confirmed outbreak case is considered a case of hepatitis A who reports a risk factor, as previously discussed, such as drug use, both injection and non-injection, homelessness or unstable housing, current or recent incarceration, and/or men who have sex with other men. A probable outbreak case is considered a case of hepatitis A who does not report any of the aforementioned risk factors, but who has an epidemiological link to a confirmed outbreak case who does report a risk factor. And lastly, a possible outbreak case is considered a case of hepatitis A with no reported risk factors, epi links to confirmed cases, and no other explanation for their illness, such as travel to an endemic country or a link to a known foodborne outbreak. As you will see on the right-hand side of the screen, there's a breakdown of total cases by our case definitions. So of the 316 total outbreak cases, 192 report a risk factor of drug use, homelessness, incarceration, or MSM. 4 cases report no risk factors but are epi-linked to a confirmed outbreak case. And 120 cases have no reported risk factors or other explanation for their illness. So on to outbreak response strategies, both at the local level and state level. In New Jersey, local health departments from the primarily affected counties have been doing tremendous work since February to outreach to the at-risk populations within their local jurisdictions. These outreach efforts primarily include Hep A education and offering Hep A vaccine. The local health departments have been really taking the approach of meeting the people where they are, and this has proven to be an effective strategy in reaching the at-risk population, who we know to be extremely transient and often hard to reach at times. The local health departments have been taking on this strategy by identifying community organizations, venues, and programs within their communities that serve the at-risk population, and partnering with organizations to go out and offer ongoing hepatitis A vaccine clinics and/or education. As you can see from the list of target areas for outreach, the local health departments have been extremely successful in leveraging partnerships through various organization types spanning across many different sectors, including faith-based, public health, healthcare, housing, transportation, corrections, drug treatment services, just to name a few. Much of the outbreak response efforts from the Communicable Disease Service is really geared towards supporting the efforts of the local health departments from a state perspective. So to ensure ongoing communication with the affected counties, the Communicable Disease Service coordinates monthly calls with the affected counties to discuss and share barriers, successes, resources, and best practices, as well as to foster communications between the affected counties. Our data team continues to conduct enhanced statewide surveillance of hepatitis A to identify increases in other parts of the state. This includes compiling, cleaning, and analyzing outbreak data to ensure that we are providing you with accurate data that's posted publicly and shared with public health partners. This data is what is updated on a weekly basis on our Hepatitis A website, which is screenshotted in the slide below. The Communicable Disease Service has and continues to create educational materials based on the feedback that we've received from local health departments expressing their needs for health education. Some of these materials include a clinical quick guide for healthcare providers and updated talking points for local health departments. Two documents that we're excited to announce should be coming soon to you include a Hepatitis A food establishment toolkit and first responder health education materials. With regard to the first responders, our educational material will highlight the point that there are currently no recommendations for first responders to get vaccinated in response to this outbreak. It's understood that hand washing and appropriate use of standard precautions should provide protection against communicable diseases that include hepatitis A. However, it does explain that if first responders who are currently unvaccinated wish to obtain immunity, they should discuss vaccination options with their healthcare provider. Communicable Disease Service also received feedback from local health departments that many of their healthcare providers within their local jurisdictions were not aware of the ongoing hepatitis A outbreak. In response to this feedback, the Communicable Disease Service is currently working on a slideshow for a clinician webinar on the hepatitis A outbreak. We hope to roll this out at the end of August. In an effort to continue to support the efforts of the local health departments, the Communicable Disease Service has also completed the following actions. A letter was drafted and sent to the Department of Corrections Commissioner regarding Hep A vaccination within the state prison system. Overall, the recommendation was to increase Hep A vaccine efforts and consider a tiered approach for targeting inmates for the purpose of conserving resources and providing vaccine to the most at-risk populations among inmates. The target populations within this inmate community include inmates on medication-assisted treatment programs, inmates that have been diagnosed with a substance use disorder, inmates that are approaching their release date, and inmates who have food handling duties within the prison kitchen. A letter was also drafted and sent to emergency department directors and hospital infection preventionists, reminding them of the ongoing outbreak, reviewing high-risk populations, and reminding them to consider providing education and hepatitis A vaccine to the at-risk populations regardless of the reason for their hospital visit. Additionally, a team from the Communicable Disease Service recently met with representatives from the Department of Community Affairs, who licenses local homeless shelters, rooming houses, boarding homes, and residential healthcare facilities across the state. The discussion was around ways in which we can partner and support the outbreak efforts that the local health departments are already doing at these facilities. The Department of Community Affairs explained their role in licensing and inspecting over 1,100 facilities throughout the state. And Communicable Disease Service asked if their evaluators can disseminate educational materials to their facilities when they go to inspect them. Each facility is inspected yearly. However, they will respond to complaints and emergencies on an as-needed basis, and we're amenable to having evaluators disseminate information and materials. Our Hepatitis A Outbreak website is also up and running with resources and materials that can be accessed whenever you would like to do so. So that is available through our Communicable Disease website. Updated county-specific case counts, hospitalization rates, and deaths associated with the outbreak are posted to this website every Tuesday under the red alert box, which is entitled Hepatitis A Outbreak Summary. Additionally, our outbreak response team continues to participate on multi-state calls with CDC and other neighboring states that are experiencing similar outbreaks. We use this time to discuss best practices, barriers, successes, and resources to bring back and share with the impacted counties in New Jersey. And here are some resources that are available to the local health departments, including our Hepatitis A website, the CDC Hepatitis A Outbreak website, all educational materials available, and the original MMWR article regarding increase in Hep A virus infections. Thank you.
Thanks, Brad. That was great presentation. Our next presenter is our foodborne coordinators, Deepam Thomas, and Deepam will talk to us about two topics today. We're still in the hepatitis A for the first topic, and the second topic that we all are having questions about it is the cyclospora. At this point, cyclospora increase in New Jersey. Thanks, Deepam.
Thank you, Sharif. Good morning, everyone. I'm Deepam Thomas. I'm the Foodborne Disease Program Coordinator, like Sharif mentioned. And today we'll first review hepatitis A and investigations that involve food handlers before moving to a quick situational update for cyclosporiasis. As Brett mentioned, outbreaks were first identified in 2016, and since March of 2017, CDC's Division of Viral Hepatitis has been assisting multiple state and local health departments with Hep A outbreaks that have been spread through person-to-person contact. And as of August 9, 2019, 29 states have publicly reported 23,978 cases, 14,330 hospitalizations, and 236 deaths. These are numbers you've already seen on Brett's slide, so we'll skip over these, but essentially we're up to 342 cases compared to 49 for the same time period, and 316 of these are outbreak-associated cases. As you've probably heard multiple times by now, individuals with the risk factors shown on the slide have been primarily associated with this increase, so people who use drugs, people experiencing homelessness, men who have sex with men, people who are currently or were recently incarcerated, and people with chronic liver disease, including cirrhosis, Hep B, or Hep C. So Hep A virus is primarily transmitted by the fecal-oral route, either by person-to-person contact or by ingestion of contaminated food or water. And contamination of a food product can occur at any point. So during cultivation, harvesting, processing, distribution, or preparation. And most foodborne outbreaks in recent years have occurred as a result of contamination even before reaching the food service establishment, and sometimes even prior to importation into the country. Cooked foods that are the culprit are usually when they're not heated to appropriate temperatures. So it's not capable to kill the virus during preparation, and that would be 185 degrees Fahrenheit for 1 minute, or foods that are contaminated after occurring. And this is what occurs in outbreaks associated with infected food handlers. Freezing does not inactivate HAV or hepatitis A virus. Waterborne outbreaks are infrequent in developed countries with properly maintained sanitation and water supplies. So in the United States, floods are unlikely to cause outbreaks of Hep A, and they've not been documented. Food handlers are not at a higher risk for acquiring Hep A than other people. However, food handlers are considered a greater public health risk than non-food handlers. This is because if a food handler works while having symptoms and also has poor personal hygiene, they have the potential to infect many people. Brett did a great job explaining case definitions. So once a case meets lab and clinical criteria, so once it's confirmed, every case of confirmed Hep A should then be assessed to determine if they fit the definition of a food handler. So a food handler is any person who directly prepares, serves, or handles food. This also includes individuals who administer oral medications to another person. So certain jobs and activities outside of the food service industry, like those who are involved in patient health, childcare services, need to be very carefully assessed to determine if the case patient is a food handler. So exclusion requirements may apply to any individual meeting the definition of a food handler, regardless if they work in the food service industry. If the case patient is determined to be a food handler and has participated in food handling during their period of infectivity, it is important to assess the onset, the duration of signs and symptoms, and the period of infectivity is really the 2 week before and the 1 week after onset of jaundice or elevated liver function tests. So the case patient's risk of transmitting the illness during this time frame, that is handling uncooked food, glove use, repeat patron exposures, is what would determine our next public health steps. Some food handler situations are an easy assessment. So an email or phone call to discuss the risk suffices. But most times, they're careful considerations through conference calls. And these usually involve SMEs for Hep A here at CDS, your regional EPI, the local health department investigator, and oftentimes an REHS. This algorithm that's shown on the slide is very useful to prioritize the level of public health response needed. Like if PEP should just be considered for co-workers or patron notifications need to be made. So if a food handler receives a diagnosis of Hep A, PEP or post-exposure prophylaxis is usually recommended to other food handlers at the same establishment. And because common source transmission to patrons is unlikely, PEP recommendation for patrons typically is not indicated, may be considered, one, if during the time when the food handler was likely to be infectious, the food handler both directly handled uncooked food or foods after cooking and had diarrhea or poor hygiene. And two, if patrons can be identified and treated within 2 weeks of exposure. In settings in which repeated exposures to HIV have occurred, consideration of PAP is again warranted. So the example for that would be institutional cafeterias. Irrespective, it's always a case-by-case assessment that is usually based on this algorithm. Also, for those of you who have worked on such food handler situations, know that there are patron notification letter templates available, and CDS typically works very closely with you to help tweak the letter to cater to the situation. So how can food handlers prevent the spread of Hep A? Very simple. Don't work when you're ill. Use good hand washing techniques, especially after the use of bathroom. Wear gloves when handling or preparing ready-to-eat food, and get vaccinated. Unfortunately, we very rarely get a food handler situation where all of these are in place. So as I mentioned before, food handlers are not at an increased risk of acquiring Hep A because of their occupation. But as the case counts increase in New Jersey, the occurrence of Hep A in our food handling population will also increase. We've had a dozen food handler cases that needed follow-up so far since December of 2018, of which only 2 warranted patron notifications. Along with sewage workers, healthcare workers, children under 12 months of age, childcare staff, CDC does not recommend food service workers to get vaccinated. Because foodborne Hep A outbreaks are relatively uncommon in the United States, CDC is currently asking states to consider vaccination of employees who work in areas where community-wide outbreaks are occurring and where state, local health authorities, or private employers determine that such a vaccination is cost-effective. Food handler exclusions. Food handlers diagnosed with acute Hep A infection must be excluded from work for at least 14 days from the onset of any symptoms that are compatible with Hep A. And based on the risk assessment that I mentioned in the previous slide, if it is determined that PEP is needed, food handler co-workers who can provide documentation reflecting prior Hep A vaccination or a serological immunity to Hep A need not receive PEP, so they do not need to be excluded from work. Food handling co-workers who receive PEP within 14 days of their last exposure to the infectious Hep A case patient do not need to be excluded. They may immediately return back to work after receiving their PEP. And the food handling co-workers who did not receive PEP within the 14 days of their last exposure to an infectious Hep A case patient must be excluded for 28 days. CDC has some really nice resources on cleaning and disinfection. And Hepavirus is a non-enveloped virus, which means it is difficult to inactivate and can live outside of the human body for several weeks. In the environment, HAV can be killed by cleaning surfaces with a freshly prepared solution of 1:100 dilution of household bleach to water. And these are a few helpful links if you haven't already seen them. And since we'll take questions at the end, I will move on to the next update on cyclosporisis. So as we all know, cyclosporisis is caused by a single-celled coccidian parasite, and most cases reported are associated with travel to an area where the illness is endemic or due to the consumption of contaminated imported produce. As with all nationally notifiable foodborne illnesses, we follow definitions based on the CST position statement. And a confirmed case is one that matches clinical criteria and lab confirmation, while a probable case is one that matches clinical criteria and is epi-linked. The cyclosporisis case report form includes questions about travel on the first 2 pages of the questionnaire, and if the case patient reports international travel during the 14-day period before illness onset, then the food exposure questions do not need to be addressed. This is a map that was posted by CDC for cases reported by states as of July 23rd. These cases have gone up since. But as of July 23rd, 2019, 580 lab-confirmed cases of cyclosporisis were reported to CDC by 30 states, District of Columbia, and New York City, in people who became ill since May 1, 2019, and who had no history of international travel during the 14-day period before illness onset. The median illness onset date was June 24th, 2019, with a range of an early May to mid-July, and at least 38 people were hospitalized with no deaths reported. For some history, in 2018, multiple outbreaks of cyclosporisis were identified and found to be linked to different produce items. So last summer, 2,299 lab-confirmed cases were reported to CDC by 33 states in people without a history of international travel before illness onset. And approximately 1/3 of the ill people were associated with either of the 2 large multi-state outbreaks in the Midwest. So the first was an outbreak linked to pre-packaged vegetable trays that probably a lot of you might have read about, which was sold at a convenience store chain. And the second was another large outbreak linked to salads. In addition, there were also some smaller clusters of cases associated with other types of fresh produce. And New Jersey had 62 cases in 2018 and did not have any cases associated with these clusters. This year is a lot different. New Jersey is seeing the same increase that many other states are seeing. These stats are as of August 8th, so they're more recent than what the CDC counts that you saw earlier. So as of August 8th, 2019, 118 lab-confirmed cases of cyclosporisis were reported to New Jersey by 19 counties in people who became ill since May 1st, 2019. These are all cases who had no international travel during the 14-day period before illness onset. For the 105 cases with illness onset dates available, the median onset date is June 26th, with a range of May 1st to July 30th. Among the 74 cases with information available on hospitalizations, 74 were hospitalized. 61% were female, and the median age for these 118 cases is 53, with a range of 4 to 84. Once again, these stats are recent and as of August 8th and do not reflect in the CDC counts that were shown earlier. So this really is a significant uptick from what we typically see, and case report forms are vitally important. Unlike many other foodborne diseases, DNA fingerprinting is not available for cyclospora, and the only tool that we can really use to link cases is finding common exposures. Information about travel and complete food histories are critical to make these linkages and possibly determining what the contaminated food product is. All completed CDS 39 forms that you send in are reviewed and entered by the CDS Foodborne Program into a CDC database, and both New Jersey and CDC analyzes the information for possible common exposures among cases. Investigators can complete the CDS-39 via the fillable PDF attached in the individual case level follow-up email, but this is not required. Handwritten completed forms are totally acceptable. Also, just a reminder, when completing these forms, the no and unknown responses are just as important as the yes. So please do not leave any questions blank. We do recognize the significant workload this has added to your already busy schedules. And while we sincerely thank you and hope that the burden of these investigations lifts soon, we continue to request that you complete the CDS-39 forms as thoroughly as possible. One multi-state outbreak of Cyclospora infections has been linked to fresh basil imported from Siga Logistics of Morelos, Mexico. FDA has requested a voluntary recall, and the firm has agreed increased import screening on basil. FDA is also working with Mexican food safety regulatory counterparts to better define the cause and source of this outbreak. And while New Jersey did have clusters where basil seemed to be a likely source, due to lack of a farm-level traceback link to our cluster investigations, FDA has not included New Jersey as part of this multi-state outbreak. It is unknown at this time if there are other reported cases of Cyclospora this season linked to fresh basil, but there are multiple clusters of cases associated with different restaurants, different events that are currently being investigated both by New Jersey and by many states, CDC, and FDA. Besides basil, other possible sources are also being investigated further. So CDC is requesting states to complete the forms without a focus just on basil. So infected people shed the parasite in their feces, but Cyclospora needs time, typically at least 1 to 2 weeks after being passed in a bowel movement to become infectious for another person. So it's highly unlikely that Cyclospora is passed directly from one person to the other. So when the parasite is found in food or water, it means that the water or food has been contaminated with human feces. So while good hygiene, so including proper hand washing, is critical, it by itself may not be enough to prevent contaminating fresh produce. So the FMCA produce safety rule requires that personnel on farms use appropriate hygiene practices. Controlling sources of contamination in the field, in the packing house, and from farm workers is really key to preventing illnesses of Cyclospora. So training farm workers, taking into consideration the varying cultural practices of farm workers when providing training, and using reputable companies that dispose of human waste into an adequate sewage system are really crucial. And for the final slide, these are resources and they include links to CDS, CDC, and FDA posting. Thanks again for the quick turnaround with the CDS-39 form, and hopefully we should be able to scale back quickly to the 2-week turnaround time with forms. Thank you.
Hi, this is Maisha Larkin. I'm part of the Regional EPI program. The next segment of this webinar is actually program updates. So we decided to start doing program updates in response to feedback from our previous communicable disease forums, where there was several responses that people would like to get brief or quick program updates when it comes to these forums. So to start us off with our first program update on rabies is Colin Campbell, our state public health veterinarian.
Thank you and good morning. I'm just going to do a general rabies update and touch on some new developments that have come on through the CDC and hopefully make this a good refresher. Okay, sorry about that. Just getting a little bit of a rough start. This slide is just a reminder. The rabies virus is a lysovirus that infects mammals and is primarily transmitted through saliva, most commonly through the bite or scratch of an infected animal. In the US, there are several variants or strains of rabies virus that circulate in animal reservoirs, such as raccoon, skunk, fox, and bat rabies variants. There is no treatment once clinical signs or symptoms of the disease begin in the victim. Regardless of the variant, rabies infections are over 99% fatal, making rabies one of the world's most deadliest diseases. However, prompt administration of post-exposure prophylaxis immediately after exposure effectively prevents the disease in humans. Okay. In June, the CDC released a vital signs report and conducted a press release on rabies prevention. This report has a strong focus on bats, as they are responsible for roughly 7 in 10 rabies deaths among people who are infected with the rabies virus in the US. From 1960 to 2019, almost 60 years, 125 human rabies cases were reported in the United States, slightly more than 2 fatalities per year. 28% were attributed to dog bites during international travel outside of the US, and 70% were attributed to bites from bats. Each year, rabies causes 60,000 deaths worldwide, approximately 2 deaths in the US. One of the reasons there are so few rabies fatalities in the US is because of access to rabies post-exposure prophylaxis. Approximately 55,000 Americans sought prophylaxis after contact with a potentially rabid animal in 2018. The low number of deaths in the US may be due to our ability to access prompt medical care, receive rabies prophylaxis. In 2018, every 10 minutes, someone in the US received rabies prophylaxis for possible exposure to rabies. About 5,000 animals, mostly wildlife, test positive for rabies throughout the US each year. Rabies was a disease initially carried by domestic dogs that were brought over to North America by European immigrants. Due to the development and use of animal vaccines, the rate of rabies in dogs decreased dramatically in the 1950s. While rabies in domestic animals decreased due to vaccination, wildlife rabies, including animals such as bats, raccoons, skunks, foxes, and groundhogs, have increased from the 1960s. Over the last decade, wildlife rabies is decreasing slightly. Each year, the CDC and its public health partners respond to about 175 mass bat exposures. These are events where more than 10 people are exposed to a potentially rabid bat or bats. The NJDOH had a similar investigation several years ago when New Jersey families volunteered for church-sponsored projects in rural Virginia and were sleeping in a high school auditorium. One of the volunteers woke up in the middle of the night to see bats flying through this auditorium, and they were counseled regarding the risk of rabies from being asleep in a room where bats were active. The majority of the impacted families chose to receive rabies prophylaxis after exposure. If traveling internationally, it's recommended to research the rabies risk at the travel destinations. The CDC vital signs recommendations warn Americans traveling outside of North America to be wary of dogs, particularly those acting aggressively or neurologically impaired. Do not interact with free-roaming street dogs. Most Americans are attracted to free-roaming dogs because we have very little dog rabies in North America, but elsewhere they can have a high rate of rabies virus. Globally, rabid dogs cause about 98% of the 59,000 human deaths from rabies worldwide. Some travelers may consider pre-exposure vaccination prior to their travel. Wildlife rabies, especially in bats, continue to pose a significant risk to humans. Americans traveling outside the US should also avoid stray dogs and any dog bites. If a traveler is bitten by a dog that cannot be observed, they should seek immediate medical care. Vaccinating dogs and cats, avoiding contact with free-roaming dogs and wildlife, and seeking medical care in the event that you're bitten by an animal can prevent rabies infections. We did have a situation a few years ago where a doctor was traveling in Asia and interacted with some dogs and was nipped by a dog. She didn't think much of it, even though she was a medical professional. She came back to the US and unfortunately started to develop rabies a couple of months later. So that was a very sad situation that we were involved with. So what does this mean for New Jersey? For rabies prevention, reduce the potential exposures to wild animals. One example of that would be bat-proofing homes. Continue to stress the importance of domestic animal vaccination. Rabies virus is established in the raccoon population of New Jersey. Vaccinating dogs, cats, and other domestic animals will form a protective barrier between the rabid wildlife and human populations. Animal vaccination is inexpensive and safe, and it is an outstanding cost to benefit ratio. Remind residents of local resources that might be available, free vaccine clinics for pets, animal control services, and consultation with local health departments. For rabies consultations, continue to conduct thorough rabies consultations to determine if an exposure has occurred. PEP should be administered if appropriate. PEP prevents human rabies, and it's important to work closely with animal control officers to locate, confine biting animals. We recommend that local health departments reach out to hospitals to ensure that they have the appropriate biologics, rabies vaccine and immune globulin, and that they keep that in stock. We also recommend local health departments providing hospitals with up-to-date rabies resources. For instance, our guide to rabies post-exposure prophylaxis to help them prevent any improper administration of PEP, and provide 24/7 contact information to hospitals in the event of a mass exposure or questions after hours. Consider providing training to local health departments, training to local ERs on properly administering rabies prophylaxis. As of today, we've had 146 confirmed positive rabid animals in the state of New Jersey. Thank you.
Thanks, Colin, for the update. Our next update is going to be given by Kathleen Ross regarding Legionellosis.
Hi, everyone. I'm an epidemiologist with the Communicable Disease Service at the New Jersey Department of Health, and we're just giving some quick updates on our program. So we're going to go over some revisions to the case definition, which was recently updated and approved at the CSTE conference this past summer, and just some upcoming reminders. So we'll go over the revisions to the case definition first. So Legionellosis, it is a nationally notifiable disease. So cases that we investigate, either confirmed or suspect, are reported up to the CDC every year. To be considered a confirmed case, you have to meet at least one of the following lab criteria. You have to be able to isolate Legionella by culture from a respiratory specimen. There's the urinary antigen test that looks for Legionella pneumophila serogroup 1 in the urine. And there's also, you can do blood collection, but we usually don't recommend that because you have to take specimens 3 to 6 weeks apart to see if there was a fourfold rise in the titer. So currently, across the nation, over 95% of cases are diagnosed just by the urinary antigen test. It's a really great test for clinical reasons. There's a fast turnaround time, but unfortunately, it's only specific for Legionella pneumophila serogroup 1. So if someone's infected with other serogroups or other Legionella species, that's not going to pick up on that. Therefore, we always recommend to do the urinary antigen test in conjunction with getting a respiratory culture. The respiratory culture is considered the gold standard because that it can identify all Legionella serogroups and species. However, a lot of healthcare providers don't prefer the dew culture. There's a long turnaround time. It can be up to 14 days. A lot of labs don't require the specialized media that you need to use. And it's also decreased sensitivity if the patient already started antibiotics. Also, laboratorians have to be trained to actually isolate the Legionella. So there's a special technique for doing that. So as a supplement, there is the nucleic acid amplification testing, better known as PCR. That can be done for respiratory specimens, and it can also detect non-LP Legionella. Unfortunately, it's not really utilized by a lot of laboratories, but it does not require any of the specialized media. It can also detect just the genetic material rather than the viable organism. Therefore, the antibiotic won't have an impact on it. Per the old case definition, it was last updated in 2005. Any cases that were diagnosed by a positive PCR were classified as suspect. And these cases are reported at the CDC, but at a national level, they only report confirmed cases. This isn't being reported out. And these lab results are pretty inconsistently reported to public health departments by healthcare providers. But since 2005, there's been an increase with using this PCR testing, and it's becoming more and more reliable and more widely used. And because of that, the Legionella work group at CSTE decided to revise the case definition, and it was voted on this past year. So to be considered a confirmed case, which we went over prior, it's culture, the antigen or the blood test, and now it is including detection of any Legionella species from any type of sample, so not just respiratory samples. It would also be including extrapulmonary sites by a validated PCR test. There are some other changes to the case definition. So there's the lab part, but there's also the clinical component. So although I think we kind of all are used to saying that there's two clinically distinct diseases associated with legionellosis, there's Legionnaire's disease and also Pontiac fever. But there are rare instances where someone will develop endocarditis caused by Legionella. Even though it's rare, it warranted enough to be included in the case definition. So we're now going to include extrapulmonary infections. Also for the incubation period, I think we've been kind of saying this for the past year or two. Currently, in the case definition, it's written as 2 to 10 days after exposure. So when local health departments are interviewing cases, they typically ask what those case patients were doing in those 10 days prior. Research shows that actually 16% of cases have an onset of more than 10 days, and 99% of cases will have their symptoms within 14 days. For that reason, we're increasing the incubation period from 2 to 14 days after exposure. So for just some program reminders, we are currently in Legionellosis season. It's in the summer and goes into the early fall. So continue to interview those case patients regarding the 14 days prior to illness onset to continue to look for any common exposures among cases. Even if there's a common exposure among multiple jurisdictions, we at the state will then overlook that to see if any addresses or locations named pop up multiple times. If you do get any case reports where someone has either exposure to healthcare, assisted living, senior living, or they reported travel, please let us know as soon as possible. If you can contact your regional epidemiologist to report that by phone or email. We're also planning some upcoming trainings, probably by webinar, focused more on the environmental aspect. So stay tuned for that. We'll likely be doing links messages to promote that. And CDC recently updated their website with some really great resources for health departments in conducting investigations. So a link for that is included here. That's it. Thank you.
Thanks for the update, Kathleen. Just as a reminder, if anyone has any questions, then you can put those in the questions box, and we will be answering questions for a few minutes, with the exception of if there are some questions, because some of our people had to leave that presented. So if there are some questions for them and they aren't here in the room, then we will email out responses to those questions. So please remember to put those in the question box. Our next presenter is Kristen Garofalo. She's one of our epidemiologists in the vector-borne program, and she will be presenting, or she will be giving a program update on vector-borne diseases.
Thank you. And we're going to begin with a poll question. Okay, so how often do you view the New Jersey Department of Health vector-borne surveillance report that's posted weekly during mosquito season? Possible responses are, I've never heard of this report. I've heard of it, but I haven't seen it. I look at it a few times during the season, or I look at each weekly report. We still have responses coming in, so just another few seconds. Okay, so it seems like we do have people looking at the report, which is always a good thing. But for those of you who have not heard of it or who have not seen it, I'm going to take a few minutes just to give you some information about it. So each week, the New Jersey Department of Health Vector-Borne Disease Program posts this vector-borne surveillance report to the Statistics, Reports, and Publications webpage on the Communicable Disease Service website. So here you can find the latest report and historical reports that date back to 2006. We also have a mailing list that will send out a reminder when a new report is available. So if you're interested in getting onto that mailing list, you can email cds-vectorteam@doh.nj.gov. And so now I'll just take a minute to walk you through the report page by page, just to show you what kind of information is available. Okay, so at the top of the page is a seasonal highlight that provides a brief summary of the overall report. So it's just kind of like your cliff notes to the whole report, and it just shows the high-level type updates. In the middle section, this section contains information on 2018 and 2019 case counts of human vector-borne disease cases. So this is both probable and confirmed cases. We don't show numbers that are under investigation, so the 2019 numbers are obviously going to be preliminary and subject to change. This bottom section is the mosquito testing section. So it provides information on mosquito testing. FEL and the Cape May County Department of Mosquito Control BSL-3 laboratory perform testing on mosquito pools that are collected by county mosquito control agencies throughout the state. Data presented allows you to compare weekly and cumulative data from 2019 and 2018. So far this year, a total of 4,831 mosquito pools have been tested for West Nile, with 41 pools from 16 counties testing positive, with the highest number of positives in Burlington County. Okay, on the second page, the chart at the top shows a comparison of West Nile positive mosquito pools from 2018, 2019, and the red line is the 5-year average. The total number of positive mosquito pools detected this season, that's the column shown in orange, as you can see, is significantly lower than the historical average. The bottom section of this page contains a table on the data of positive Eastern equine encephalitis mosquito pools. We refer to that as EEE. So this table compares, again, weekly and cumulative positive mosquito pools from 2018 and 2019. So far in 2019, we've tested
4,360 mosquito pools for EEE. 18 mosquito pools from 7 counties have tested positive, with the highest number of positives in Gloucester County. This line graph at the top shows the number of positive EEE mosquito pools by week from 2012 through 2019. So 2019, shown in red, shows the EEE positive pools exceeds the total number of positive pools in 2018, and the highest number of positive pools reported at week 31 in the past 7 years. So we are seeing quite an uptick in EEE so far in 2019. This section of the report describes the detections of other viruses in mosquito pools in the state. In 2019, Fell and Cape May County Basil 3 lab brought on capacity to test for some new viruses as a panel. So now mosquito pools from all counties have been tested for other arboviruses, including St. Louis encephalitis virus, Jamestown Canyon virus, La Crosse encephalitis, chikungunya, dengue, and Zika. This table shows the number of pools tested for other viruses and positive detections by counties. Positive pools for Jamestown Canyon has been detected in Bergen, Burlington, and Sussex, and 1 positive La Crosse mosquito pool was identified in Passaic County. Moving away from mosquito testing, this report also contains information on equine, avian, and other animal testing. Equine testing for West Nile and EEE is conducted at the New Jersey Department of Agriculture's Animal Health and Diagnostic Laboratory. 2 equine cases of EEE have been reported from Ocean County in week 30. This is the earliest report of equine cases in the state since 2012. These surveillance maps is a visual representation of mosquito, equine, and human, West Nile, EEE, and Jamestown Canyon, and La Crosse virus activity across the state that was previously displayed in other areas of the report. Just kind of gives you a little visual representation of the different areas that are being affected in the state. Okay, and this is the last section. The syndromic surveillance for tick-related emergency department visits section is new to the report since 2018. This chart shown on the screen represents New Jersey residents seen at emergency departments statewide with a tick bite complaint or signs and symptoms associated with a reported tick bite. Tick-related emergency department visits occur throughout the year, with peak number of visits in the summer months and a smaller peak in the fall weeks when the adult black-legged ticks are active. As of week 31, the number of tick-related ED visits is comparable to trends we've seen in the past 5 years. Before wrapping up my presentation, I just wanted to share some information with you. We're very excited to announce that we've moved to a new vector-borne disease surveillance system, which provides improved data sharing and analysis on vector and environmental side. So included in the system are outward-facing public maps of our mosquito data. So I'm just going to take a minute to show you the website and some of its functionality. Can I click on this? Okay, it's loading, but so these are the outward maps. When you first click on the link or pull up this website, it is going to default to California because this database is actually created and run by the University of California. And so if you just zoom out, you'll see that Utah also is a part of this platform, and so they have their data in here as well. So you just want to scroll over, and there we go. So this map it's really cool, and it's a great way to see what's going on in the state. On the right-hand side over here, you're able to select which type of positive pools you want to look at.
And in this section, you can pull up the time frame that you want to look at. So let me just play around with this and I'll just show you. So right now I have it set, let's put it just for this year. And it'll adjust the map and you can check off. Going a little slow. Okay, so you just select the ones that you want to see. So here I have selected West Nile, La Crosse, Jamestown, and Triple E. And this shows the positive mosquito pools within the state that we have so far this season. But if you wanted to go back and you wanted to pull up another year of data, you could go to 2018 and the map will update. It doesn't look like it did, but it will. There we go. So it's a really cool way to just kind of see what's going on. You can look at the historical data of your county as well as of other counties. If you're interested in looking at, let's see, information on how many submissions were put out, I don't see, oh, there we go. So if you hit show surveillance in the bottom left corner, you'll kind of see the more blue-green areas are where more mosquito pools were being submitted. So you can see those more urban areas around Trenton and closer to Philadelphia are submitting more mosquito pool testing. And so it's just a really cool map. I just wanted to let you know that it is available and you should check it out. And that's it.
So we're going to go ahead and start our Q&A section. I think one of the last questions that was asked during Kristen's presentation, if she could give out the email address again to receive the report as well as the web address.
Yes. So here on the screen is the web address. It's https://maps.calsurv, CALSURV.org. And it is printed on the top of the slides. And the email address to get onto the mailing list for reminders for the report is CDS, as in Communicable Disease Service, Vector Team, VECTORTEAM, at DOH.NJ.gov. Oh, and let me show you again where the where you can find a copy of the report. And so this is it on the top of the screen. It's www.state.nj.health/cd/statistics/arboviral-stats. And that is on the Statistics, Reports, and Publications website on the Communicable Disease Service webpage.
Thank you, Kristen. Our next questions are regarding Legionellosis. So we have Kathleen Ross here. Let's get to, okay. So one question is, will the disease manual chapter be updated with the new case definition?
Yes, so currently the way that the case definition works is that the CSTE, the Council of State and Territorial Epidemiologists, they're the one who vote on the proposed case definition, and then it has to be formally adopted by CDC. So once that happens, we'll update the chapter online, and we'll be sure to include notifications out to the local health departments that that's been updated.
And then the next question regarding Legionellosis is, has Legionella been linked to airplanes?
So specifically for Legionella, we know it lives in water. So most of our outbreaks are linked to water sources such as hot tubs, decorative fountains, cooling towers, and building potable water systems, the plumbing systems inside. There has been some instances where people have just done research to see where they can identify Legionella. So an example would be some cars, people will put water in it instead of wind washer fluid. So that's an example of where it can be isolated. I'm unaware of any cases specifically linked to an airplane. But in theory, you have to have that water source, and then there has to be a mechanism for it to be aerosolized. So typically we see things like showers, fans, misters.
Okay. Then we had a couple of Hep A questions. Deepam Thomas left the room, but we still have Brett Nance here from our regional EPI program. So she's going to answer a couple of the Hep A questions.
So one of the questions that we received, can you clarify how the new Hep A case definition is different from the old one? So I'll start by saying that first, you actually can also look up the different case definitions from different years. So if you Google CSTE hepatitis A case definition, you can look at the 2012 versus 2019 to actually look at the difference. However, the new case definition includes the sign or symptom of dark urine in that clinical criteria. Additionally, the old case definition just had jaundice as a clinical criteria. The new case definition has jaundice or a bilirubin of 3 or greater. The old case definition also had just elevated ALT or AST values for clinical criteria, and the new case definition indicates an elevated ALT of over 200. Additionally, we used to use a probable case definition, which is no longer used for hepatitis A.
Okay, so the next question. So our next question, our next questions will be answered by Dr. Campbell regarding, I think there's rabies PEP questions.
Okay, the question is, we've been told that walk-in medical clinics now administer post-exposure prophylaxis. However, there seems to be no proof of sign-off on the administering series, completing PEP, available when the patient is asked for proof. Anytime post-exposure prophylaxis is given, that is reportable to local health departments. So you should be getting a report on that. There is a CDC-2 form that you can use to collect the information, and once you have a copy of that, we request that you send it to us so we can supply CDC with that data. So they should comply exactly the same as any other medical facility as far as administering post-exposure prophylaxis. And one more for me. Let's see, how confident would I be if bitten by an mammal in a foreign country, possibly third world, in the proper administration of PEP? That's a pretty good question, but it's a pretty subjective response. In different countries, they have different prophylaxis protocols and medications. So what I would recommend is to research, if somebody wants to get an answer to that question, research the country in the CDC Yellow Book, and that will give them some insight into the quality of the prophylaxis biologics that they have there. It is variable, it is different. If you run into a situation where somebody starts post-exposure prophylaxis in a foreign country and needs to finish it here, we can usually work that out, and if necessary, we can consult with CDC. And then somebody's clicking something else. Why rabies vaccines given on 037 should be 14 for a longer period, and what if someone misses day 1 or day 2, I guess. So if the question is what happens when there's a gap in the prophylaxis regime, you would restart where you left off. So let's say somebody was bitten and got the day 0 and day 3 doses, and then didn't come back for the day 7 dose, whenever that day 7, wherever that day 7 dose should have been, you would just pick up there when you left off. So if they came, let's say 10 days later instead of 7 days later, you would give it as soon as possible, reset the protocol for the next and last dose. I hope that makes sense. Uh-oh, there's more for me. It's tough being popular. How common is rabies in feral cats? That's a great question. We could talk about that for a long time. In general, domestic animals are fairly low risk for rabies, particularly dogs. We rarely see dogs in the US with rabies. Cats are a little bit of a different issue. The vaccination rates in cats are a lot lower. A lot of cats are free roaming. There's some cat colonies that may or may not vaccinate the cats on a regular basis. So we do consider free roaming cats to be a higher risk than other domestic animals. Is there another one?
Lost one.
Okay, here we go. Sorry. Okay, are these providers of PEP being reminded of that requested follow-up form or protocol of reporting to local health department? I would put that on the local health department to reach out to them and make sure that they are reporting to you as appropriate. Like I said, there is a form that can be used. It's a fairly straightforward process. So we have not put out like a links message or something like that, but it is important that you make sure that the vaccination was done correctly for post-exposure. How long does one have to get rabies post-exposure prophylaxis? Well, the easy answer for that is as soon as possible. It sounds kind of like a cop-out, but if there's been a long delay between the bite or exposure, you want to start that as soon as possible. Sooner is always better than later. Ideally, you should start the prophylaxis within a couple of days. As that delay period gets longer and longer into a week or 2 weeks, that patient could be at jeopardy if indeed that bite was from a rabid animal. So it would be as soon as possible.
Okay, this is Kristen, and I'm going to answer a few questions on the mosquito testing. So let's see. Does New Jersey test the resident mosquitoes more often than other states? That's a really good question. I don't know exactly how many mosquito pools are collected in other states, and based off the size and population, what that would mean. However, the surrounding states around New Jersey do test the mosquitoes. And similar to us, they do have a surveillance report available. So if you want to go to some different websites of, for example, New York City, New York State, Philadelphia, Pennsylvania, you can do a Google search and kind of see what those surveillance reports have available. And then there's another question about should public health agencies be alerting the public of EEE? During mosquito season, it's always highly recommended that local health departments are communicating with the public about risks for EEE, as well as other arboviral diseases such as West Nile. And so I do think that would be a good idea. It's a good opportunity to work with your health educators, communicators, to make sure you're getting out the proper prevention messages. If you speak with a physician who has a patient that has a severe clinical presentation, we do provide human testing at FEL for Powassan if it's potentially tick-related, or Eastern equine encephalitis, and we can also reach out to CDC for any type of additional arboviral testing that may be needed.
Okay, that looks like it's the end of our questions. I know there's a few more questions that were on there, but these are questions that would probably apply to Deepam, who, like I said earlier, she had to go to another meeting. So you will get an email response in regards to those questions. So thank you all for attending our webinar today. Remember that the next upcoming forum is going to be October 29th from 9:30 a.m. to 11:30 a.m. We'll soon put that on NJLMN. Also, in regards to the credits offered from this webinar, we'll be sending an evaluation through NJLMN after this session. You will have to do the evaluation and then you will get credits. So we'll try to get on that as soon as we can. And thank you all for attending our webinar this time, and we hope to see you all in October.